You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is October 6, 2023. Our topic is perioperative reactions, presented by Dr. Aleena Banerji. She is an associate professor of medicine at Harvard Medical School and the clinical director of MGH Allergy and Immunology in Boston, Massachusetts.
So today we have Dr. Banerji with us. Dr. Aleena Banerji is an associate professor of medicine at Harvard Medical School and the clinical director of the Mass General Hospital Allergy and Immunology Unit. Dr. Banerji's research interests are centered on the field of drug allergy and angioedema, and she's going to be talking to us about perioperative hypersensitivity reactions. We're very glad to have you here with us today, Dr. Banerji.
Wonderful. Thank you for having me, and I'm happy to take any questions as we go, so please feel free. Otherwise, I will kind of get through the slides and the material, and we can talk a little bit more if you have specific questions or cases at the end. So my topic today is about perioperative hypersensitivity reactions. I have no disclosures relevant to this talk, and really just talk a little bit about background and epidemiology first. And then I'll present kind of a common clinical approach to the reactions, and then think about how you might want to evaluate someone who has had a presumed allergic reaction in the peri-op setting when they present to your office. And then really an area that I think is more important even is how do you then approach the case when the allergy evaluation and all of your tools don't identify a culprit and that individual needs to go back for a procedure, go back to the operating room for anesthesia. So we know that part of the challenge is that in the peri-op setting, there are numerous exposures that are simultaneous, including a number of drugs and non-drug exposures. And there's really no standardized approach at this time, although it's needed. And the Europeans have certainly moved the field a little bit forward, but that makes this challenging. One of the things that we've learned is that key collaboration between the anesthesiologist and the allergist is really important, but it gets complicated because we're often seeing the patient, weeks to months or even years after the reaction occurred, and so that can be challenging. And then one of the key tools is our tryptase level, and it's almost always impossible to have it during the reaction because, again, we're seeing this individual much, much later, but that is something that we're trying to put out there across the spectrum of allergic reactions. And so to cover kind of our first main topic is to think about the epidemiology. We know that the studies that are out there are very heterogeneous. Some are multi versus single center, some are prospective versus retrospective. There's a lot of differences in the approach, in the skin testing, the local practices. And so that's led to quite a bit of heterogeneity, and the incidence can range anywhere from 1 in 3,500 to 1 in 20,000. So clearly a huge range. And again, it depends what country you're looking at, how much expertise there is, what types of drugs you're thinking about. But what we know is that there is still some level of mortality, somewhere in the range of 3 to 6% in the literature, which is why it remains such an important topic. So to talk a little bit about just general clinical approach when a reaction occurs, one of the most important things to think about is when a reaction occurs and that individual is referred to us, there are many reasons for that reaction. It doesn't necessarily just have to be allergic. And I think that's an important teaching point where there are specific medications used in anesthesia that can cause hypotension as a side effect. Also, manipulating the airway can cause symptoms that suggest that there's a respiratory component that could mimic an allergic reaction. I think oftentimes the default is to consider an allergic reaction. But when we're seeing that individual, this is really important to remember that there's a lot of side effects for medications or other reasons that hypotension or difficult airway can occur. So, for example, we know that certain anesthetic agents, as I mentioned, can cause hypotension. They can also cause bradycardia. We know that local anesthetics or nerve blocks, if they're accidentally administered intravascularly, those can cause certain symptoms. We also know that airway manipulation or the effect of surgical techniques can cause bronchospasm or laryngospasm. And then we know that things like pulmonary edema, amniotic fluid embolism, pulmonary embolism, pneumothorax are complications of surgery that can cause symptoms that can cross over with presumed symptoms of a hypersensitivity reaction or anaphylaxis. And then there's also data to suggest that there's certain underlying conditions that can predispose someone to have a hypersensitivity reaction or to have allergic reactions, such as systemic mastocytosis. So those are all the things that we have to keep in mind when we're seeing these individuals. And so the next 3 slides kind of give you a very broad differential of different symptoms without the tryptase increase if you're able to get it. So for example, if you have just isolated hypertension, it can often be mistaken for an allergic reaction. But we know that, for example, pulmonary embolism or amniotic fluid embolism can cause isolated hypertension. We also know that anesthetic agents or the neuroaxial blockade can cause isolated hypertension itself. And so this is a really nice publication with this differential for isolated hypertension. And then similarly, isolated bronchospasm could be certainly uncontrolled asthma or airway hyperreactivity. It could also be inadequate depth of anesthesia. It could also be that the ET tube is malpositioned. There could be a component of aspiration. Again, rare, but these are all the things to think about when you're evaluating these individuals. For isolated angioedema, certainly thinking about ACE inhibitors or acquired C1 inhibitor deficiency, or edema or soft tissue swelling that can happen because of manipulating the airway or if it's a difficult intubation. And then lastly, isolated skin symptoms or combined skin symptoms with hypotension and tachycardia could be related to oxytocin. It could be aggravating underlying chronic urticaria. And so those are really kind of a broad thought process to think about as you're seeing these individuals to try to understand if it's an allergic reaction. So let's go on to how we think through in the clinic. So now we're really thinking about the allergic or hypersensitivity reactions that can occur. And so what we typically will try to do is when a reaction occurs, ideally you want to evaluate that individual within 6 months when we're thinking about skin testing. There's some data to suggest you're going to get false negative skin tests if you skin test too early, and there's publication recently that we'll talk about. And certainly if you skin test a year or 2 or 10 years later, that there may be loss of the IgE over time, as we see in other allergic conditions. And so you may get a false negative, or you may not be able to capture what caused the reaction. And so when we're referred these cases, we try to evaluate them in our clinic within that 4 to 6 weeks out to 6 to 12 months time period. And what does that include? That includes a comprehensive history, as we always do, looking at the medical records, and specifically the operating room report, where you have a graph of the vital signs, you have a record of what medications were given and exactly what time and doses. We always try to get a baseline tryptase, even if we don't have a tryptase level during the reaction. We always want to get a baseline tryptase, because if it's elevated, it certainly gives you a lot of information. And then we always think about getting a latex IgE in the context of a total IgE, because we still see very, very rare cases, but very rare cases do exist of latex allergy. And so after we do that, then we think about skin testing and or challenges. And this is just based on what is in the literature for non-irritating skin test concentrations from the variety of agents that could have been given during that procedure. And if there is an agent or drug that was given and it's positive on skin testing, that's great news. You have an answer. It's black and white. You can really attribute the reaction to that drug or whatever was positive on skin testing, document the allergy, and then avoid it. However, I think things get more complicated when you go through the whole process. Everything is negative. In the US, we don't really have a lot of basophil activation tests. Drug challenges can certainly be considered because they're the gold standard when we're using non-irritating skin test concentrations. If the skin test is negative, it's certainly helpful, but it doesn't 100% rule it out. And so you often need the drug challenge to have a definitive answer. And that's possible with antibiotics, for example, but it's not possible with the neuromuscular blocking agents in our outpatient clinic. And so those are the ways to think through when you do have negative skin testing. And then in a lot of cases, there are agents that we don't have non-irritating skin test concentrations to. And so when you're going back to the operating room in those situations, you have to think about avoiding that agent or avoiding cross-reactive agents. You could consider doing an inter-op test dose if that drug or agent has to be used, and then certainly trying to have increased time intervals when that individual goes back to the operating room and you haven't found something that's positive on skin testing, so that there's a little bit more time between the different drugs, so that if a drug was to cause a reaction, you'd have a better sense of what caused the reaction. And if you're not able to evaluate for latex, you could always consider using a latex-free environment. So some of the ways to think through, certainly if it's skin test positive, great, we have an answer. If it's skin test negative, think about doing challenges to get a definitive negative evaluation, and then certainly a way forward if you're not able to skin test, which is certainly the case with a lot of the drugs that are given. And so what are the possible causes? And the list is huge, as you can see. Antibiotics are the most common, followed by neuromuscular blocking agents, then latex. And then we often see reactions to the hypnotics like propofol. Certainly the opiates, fentanyl, for example, can cause direct mast cell activation. Aspirin, NSAIDs, antiemetics, the colloids, the chlorhexidine, local anesthetics, protamine, heparin, the dyes. We've seen literature on methylene blue causing anaphylactic reactions. Things like oxytocin, sugammadex is a newer culprit that's been found, and then certainly different excipients. And so the list goes on. But these are all the things to think about when you are seeing these individuals. So the neuromuscular blocking agents, when you look at the European literature, are the most common cause, specifically in France, Norway, and Belgium, but less common in the United States, Sweden, or Denmark. And again, this is often due to geographical variation and the idea that these presumed allergic or anaphylactic reactions occurring with first exposure has been attributed to the fact that there's some cosmetics that contain quaternary substituted ammonium groups that could cross-sensitize patients with the neuromuscular blocking agents, so that they're already sensitized when they get it in the operating room. We also know that there's some antitussive agents that could be contributing to this. And when they banned these agents in Norway specifically, there was a decrease in the incidence of neuromuscular blocking agents. And so even if it appears to be a first-time exposure, there are some agents that are out there that are in use, both as antitussives and cosmetics, that could predispose someone to becoming sensitive or sensitized to the neuromuscular blocking agents. And then antibiotics, as I mentioned, are certainly the most common cause in the United States, but also in Spain and the United Kingdom, and accounted for almost half of perioperative hypersensitivity reactions. And in France, the antibiotics are in second place after the neuromuscular blocking agents, and certainly a lot of data suggesting that cefazolin, which is probably one of the most commonly used prophylactic antibiotics, as being the most frequent cause, at least in the United States. And then latex, I think the number of cases has gone down over time. And a lot of that is due to the improvement in the quality of the product and reduction in the amount of powder in the latex gloves. And so there's just less exposure to latex and therefore decrease in sensitization. And so, it's maybe the fourth or fifth cause and even a minor cause when we think of that big list of drugs or agents that can cause perioperative hypersensitivity reactions. Chlorhexidine has become very well recognized as a very common cause. And in the European literature, it's routinely tested for in individuals who've had a perioperative hypersensitivity reaction. I think there is literature in the US as well as France showing that it's a cause. And a lot of this is likely either due to under-recognition of chlorhexidine or slight differences in disinfection practices and not necessarily using standard approach to testing the chlorhexidine. But the exposure to it is through the skin, through central venous catheters, as well as urethral or other lubricating gels. And oftentimes, the use of chlorhexidine may not actually be well documented in the operating room, just depending on the location and the way that the operating room is set up and the documentation is set up. And so that's something to think about, that there may have been chlorhexidine applied, but not documented. So what can we do? I think we've talked a lot so far in the first 15 minutes about non-allergic reasons for isolated hypertension or bronchospasm, but also allergic causes. And you can think about risk factors such as having an elevated baseline tryptase level, recurrent procedures where you've had multiple exposures to some of these agents, or sensitization in some other ways. And then what can we do? We can skin test. We have a lot of data on non-irritating skin test concentrations to a number of the agents that I mentioned are in the differential diagnosis. And then based on whether it's skin test positive or skin test negative, or you can't skin test you, I kind of walked you through the algorithm for how you then proceed if that individual needs to go back to the operating. And so here's just a screenshot. I shared my slides so you can pull it from the slides, but this is also published in JACI in Practice. There's a lot of data that goes over the non-irritating skin test concentrations to a variety of the agents that are used specifically for anesthesia. So here's a paper from work that our group did looking specifically at the etiology of perioperative reactions in the United States. And in this paper, we looked at 123 individuals that had been referred to our clinic for perioperative reaction, and 118 of those did complete the full evaluation, which includes tryptase level at baseline, the latex, IgE, all the skin testing. And here's what we found. We found that of the 118, going through everything, 28 were skin test positive and 90 were skin test negative. And these were individuals that were referred to allergy with symptoms that really were felt to be a perioperative hypersensitivity reaction. So good in that we found 28 that were skin test positive, but certainly leaves us with kind of a challenge where 90 patients were skin test negative and really didn't have an etiology. And so let's look at those 28 patients. So the 28 patients that were skin test positive, as you can see, antibiotics was the etiology in 17 of those, and 13 of those were cefazolin. So as I described earlier, it's the most common cause. We found a couple of ciprofloxacin, a vancomycin, one penicillin, one levofloxacin, just a smattering of other antibiotics. And then in the non-antibiotic group, we found 3 were skin test positive to ondansetron. So again, the antiemetic. Several local anesthetics, 3 to latex, 1 cisatracurium, 1 cicilcholine, and 1 to bacitracin, again, a topical antimicrobial agent that's sometimes used. So this gives you kind of a quick glance, one paper, one research approach looking at what are the most common culprits when you go through the skin test. And so what about the timing of skin testing? I had mentioned to you a little bit about that 4 to 6 week time frame where oftentimes, whether it's food allergy or a drug allergy, we prefer not to skin test too soon within that 4 to 6 week time frame, because we believe that maybe with the mast cell degranulation that you might have a false negative skin test. And so this was a paper that looked specifically at testing early and late in individuals with perioperative hypersensitivity reactions. And let's look at what they found. So optimal timing is unknown as their initial hypothesis going into it, and it's thought to be best at least 4 to 6 weeks after an event. And so they looked specifically at that, where individuals in this project were stratified either within 6 weeks, 6 weeks to 6 months, or greater than 6 months. And then they looked at specific IgE, basophil activation to rocuronium, and also skin testing. And what did they find? In even those individuals that had less than 6 weeks skin testing, they did have individuals here, 49 or 74% in that group, that they had an etiology that was found. Similarly, in the 6 weeks to 6 months, which is the recommended timing, and the late timing, which is greater than 6 months, they also had skin test positivity, 60% or 50%. So again, it was still identified later, but what they were showing here, that is, even when you skin test within that 4 to 6 weeks, 74% of individuals were skin test positive during the group. What they didn't do is look at those 25% that were negative on skin testing to see if they were skin test positive after that 4 to 6 weeks, which is really the important question: is, are you falsely skin test negative early and then convert to positive? But suggest that if you do have to go back to the operating room and you're within that 4 to 6 week window, it is reasonable to go ahead and try to do some skin testing to see if you can identify a positive agent. So I think, as I was saying, there are data to suggest that you can evaluate relatively early, and it's something to think about when that individual does have to go back to the operating room pretty quickly. And so, the last topic that I wanted to cover is, what about when the allergy evaluation is negative, where you've kind of proceeded with an evaluation, approached the skin testing, the latex IgE is negative, you've done latex exposure, and you don't have a cause. And that's the most challenging, is really then this individual needs to go back to the OR. They had a presumed reaction, whether it's allergic or not, it's not clear. And so how do you guide that individual when they have to go back to the OR? So I think really the most important thing is to kind of reevaluate from scratch. Go through the case, go through the chart, talk to the anesthesiologist if you can. Think about your skin testing dilutions. We don't have a lot of basophil activation testing, but certainly to think about that. Think about drug propagation if it's possible. You can always repeat the skin testing if you feel that the testing was done too soon. Look through the chart again. Are there any hidden allergens? Was chlorhexidine used and it wasn't documented? And then to think about, was this isolated hypertension? Could it be explained by something else? Was this isolated bronchospasm? Could it be explained by something non-allergic? So again, kind of going back to the 101 of perioperative reactions to identify, is this allergic or not? And so then I want to go back to our work that we had done in this field, that saved 123 individuals, where we contacted them by phone to understand if they had gone back to the operating room after their allergy evaluation. And of the 123, we were able to contact 111. And of the 111 that we contacted, they had all of their allergy evaluation completed. And 85 of them did go back and have subsequent procedures. And reassuringly, 78 of those 85 did have anesthesia again without any problems. But 7 had subsequent reactions. And when you looked at those 7 individuals, so 85 went back and had subsequent procedures, 7 of those had reactions again, despite our evaluation. And 2 of those individuals were individuals that we had said, you were skin test positive, avoid this drug, but they still had reactions. And one of those individuals did have an elevated baseline tryptase. And then there were 5 individuals that had gone through the evaluation and were negative on skin testing. And so I think that there's still a bit more work to do, because 7 out of 85 is just under 10% still having subsequent reactions. Granted, it was grade 1 to 3 reactions and no one had severe anaphylaxis using that grading system, but it's still a challenge if that number of patients going through what we thought was an appropriate evaluation have to go back to the operating room and there are still subsequent reactions. So I think really, to summarize, I think that the evaluation and diagnosis of these reactions remains difficult. I think that there's a lot that happens very quickly in that setting, and a lot of these reactions may not be allergic. There's such a wide differential, and I think we need to collaborate more closely with anesthesia. And I'd love to find a way in the US, like Dr. Leanne Garvey does in Denmark, to be able to challenge to some of the anesthetics, because we're really limited with just having non-irritating concentrations for skin testing. It'd be really nice to be able to find a way to do some challenges with some of these medications, which is complicated because they're anesthetics. I think there's still increasing recognition of causative agents such as chlorhexidine in the United States, also sugammadex, and I think that we'll find that there are other agents that we're just not recognizing, and be able to better guide these individuals who need to have surgery again, even though there's a negative evaluation. And I think that skin testing is great, but it's not enough because we're using non-irritating concentrations. But that's true across the spectrum of drug allergy, about the field of drug allergy, that we need better tools. Basal activation, again, has some promise, but has limitations. So I think we still have a lot of work to do, but hope.